Well, welcome everyone on behalf of the Jacksonville Urban League Center for Advocacy and Social Justice. We're excited to have with us tonight Doctors Frank Catalinodo and Dr. Carl Self. We've been working with Dr. Catalinodo for quite some time, looking at the data on access to oral health and the serious impacts of the lack of access to dental care, the impact on people generally, people that can afford and yet don't access it, and people that cannot afford it. And of course, you know that the Jacksonville Urban League focuses on underserved communities. So we're very grateful for the work that he has done and Dr. Self to try to provide more access to individuals, particularly those in underserved communities, to this very critical health need. With that, I will turn it over to Maura Mintner, an intern at the Jacksonville Center for Advocacy and Social Justice. Also with us are Sophia Berger, Jamie Krasnigor, Julie Miller, interns at the center as well. And also I see Pallavi Nagdevi has joined us. And with that, I'll turn it over to Maura.
Hi everyone, my name is Mara Minter. I'm a pre-dental student at Johns Hopkins University, interning for the Center of Advocacy and Social Justice. It is great to see so many people here today. This town hall will discuss social responsibility and dental health. I am very excited to introduce one of our speakers, Dr. Frank Catalinodo. Dr. Frank Catalinodo is a former dean and currently professor at the University of Florida College of Dentistry. His professional interests include social responsibility, oral health inequities, and racial equity. Dr. Catalinodo's current advocacy efforts are focused on new emerging oral workforce models. He is a vice chair of the National Coalition of Dentists for Health Equity and a co-chair of the National Partnership for Dental Therapy. He is a founding member of Floridians for Dental Access. And some background on his organization, FLDA. Floridians for Dental Access was started in 2018 by Dr. Frank Catalinodo in collaboration with the PEW Trusts. Dr. Catalinodo has been a long-term advocate for dental therapy since it started in Alaska around 2005 and has provided legislative testimony in a number of other states. When asked why we didn't have a similar effort in Florida, he always responded, "You don't know how powerful the Florida Association is in terms of lobbying the state legislator." The coalition now has over 65 organizational members and is growing. We are focusing on two major goals. The first is educating the public and legislators about the access to care problem, and second, how dental therapy can be one of the solutions to improving access to care for all. Now I'm going to share my screen with Dr. Frank's PowerPoint.
Great, and you can just go to the next slide, Mara. Thank you very much, everybody, for taking the time on a Tuesday night to spend some time with us discussing what many of us consider to be a very important issue. So there's three basic things that I'm going to try to cover in the next 15 minutes, and that is a reminder to all of us of why good oral health is important. The next section will discuss what I call the sad state of oral health in Florida. We have one of the most problematic states in the country. Our data just looks not very good. And then I'm going to discuss one of the ways that we can help improve on this access problem in our state. There are other ways, but our focus is going to be on dental therapy. Next slide. And here is where this, and don't go to the next slide yet, but stay on this slide. But this slide and the next slide is where the social responsibility aspect comes in for me. One of the organizations that I have worked with is the National Coalition of Dentists for Health Equity. And this is one of the founding principles of our organization, a statement by Martin Luther King many, many, many years ago, but still important today. Of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And that is particularly, I state that in our country, the richest and smartest country in the world. Next slide. Next slide, Maura.
I think I moved to the next one.
Oh, okay, good, that's it. And essentially, I'm not going to read all the words that are on this report. And by the way, my slides are available. If you write to the Urban League in Jacksonville, one of the people that organized this, they are free to send you my slides. But what this slide is saying is that oral health inequities are not randomly distributed in our country and in our population and in our citizens. There are specific groups that suffer more of these inequities. And those groups are racial and ethnic minorities and low-income people. And as dentists, we have a code of ethics, and that includes a moral responsibility to do what we can, a social responsibility to do what we can to change these inequities and to improve the oral health status of everybody. Next slide. So when people think about oral health, they think about fresh breath, they think about a pretty smile, and they don't recognize and know that oral health and poor oral health affects a whole host of life functions. The ability to eat and drink, diet, nutrition, a person's self-confidence when they're going for a job, their social function, employability, promotability, and earning potential. And people who disproportionately experience oral health inequities carry these disadvantages into all of their life functions. But next slide. But there are more important issues that have come to light in the last 15 or so years in the scientific literature. And that is the link between poor oral health and multiple chronic and systemic diseases. And in particular, the literature is very strong related to diabetes, cardiovascular disease, and low birth weight preterm babies. And so we try to urge the entire public, the policymakers, the legislators, to remember that we're not just talking about a healthy smile. We're not just talking about clean teeth. We're talking about the potential effects on other systemic diseases and how they impact people. That's in the adult issue. Go to the next slide. And there is now well over 1,000 papers. I was actually surprised. We were doing an article just a couple of days ago, and it was a review of the literature relating poor oral health negatively impacting children's school performance. Over 1,000 papers in the international literature on this. And it is very clear now, when a child is in dental pain, when they have a toothache that is a tooth that is unfilled and is painful, they don't learn as well as other children do. So that's why this is important. New slide, please. So let's discuss a little bit about our state in Florida. Dental health professional shortage areas are defined by the federal government as an area, a zip code, it could be a county, it could be a region that doesn't have an appropriate dentist to population ratio to meet the needs of the public. The worst state in the United States, Florida, with over 6 million people in our state living in dental health professional shortage areas. And if we only use dentists as a way to remedy this, that would need over 1,300 dentists. It is not going to happen. That will not happen. Next slide. Another metric that we look at is children who are eligible for Medicaid are allowed to have at least one dental examination per year. And the percentage of those children that actually did get a dental service is something called Medicaid utilization. The rest of the country is not doing too good. You can see that average is 52.3% there in sort of the middle of the chart. Florida is fifth from the bottom, with only 43% of our children getting a dental exam. No wonder, you're going to see another slide in a minute. No wonder we have the bad numbers we have. Next slide. Okay. So this looks at that data in a little more detail. And what 42% means that in 2019, over 1.4 million children did not get a dental visit that year. Next slide. Okay, so ignore the word Alachua County in this. I want you to just focus. This is untreated cavities in third graders. Third graders are a national standard that public health people use to sort of get a check on how one state is doing compared to another. And you can see that untreated cavities, Florida is seventh from the highest in the country, with over 25% of third graders having an unfilled cavity. I will never forget when I visited a county, I will not mention the county right now, to help one of our graduates who was the public health dentist in that community. We did a surveillance study. 1 in 5 children in that school system were in dental pain. They had more than an unfilled cavity. They were in pain that day, dental pain. How are you going to learn if you have a painful mouth? Next slide. This is the number that I hope shocks you. So when a poor individual who can't afford to go to a dentist has a toothache, they go to the hospital emergency room because by law, the hospital is required to see them. And in 2019, there were 152,000 visits in our state alone to hospital emergency departments for dental pain. 4,335 people actually had to be admitted to the hospital because the infection was life-threatening. And those hospitals billed out over, it's actually a little over $600 million to Medicaid, to private insurers, but a large number of those were no pays, which means the hospital sort of had to eat those dollars. All right. And the only thing that happens in a hospital emergency room is you're given antibiotics and pain medication and you're told to go see a dentist tomorrow. Well, if they couldn't afford a dentist today, they're not going to be able to afford a dentist tomorrow. All wasted money. Next slide. So, what is the biggest impediment to people accessing dental care? Two major issues, but by far the most important one is costs. People just cannot afford the high price of dentistry in private dental practices. I don't blame dentists for that. Of course not. But people cannot afford the high cost of dental care. And then the second issue is oral health literacy. They don't understand the importance of keeping your teeth healthy, keeping your mouth healthy, and what its impact could be. Next slide. So that's Dr. Self's is going to present a little bit more about dental therapy. But if you want any more information, please feel free to contact me directly. Please feel free to look up any of our organizations that are listed on here. But in particular, our statewide coalition, Floridians for Dental Access, we're always looking for new organizational members. We'll handle questions after Dr. Self does his presentation. Maura, back to you. Thank you.
Thank you, Dr. Frank. Now I will introduce our next speaker, Dr. Self. Dr. Carl Self has a DDS degree from the University of Minnesota's School of Dentistry and his MBA from the Carlson School of Management. During his career, Dr. Self has practiced dentistry in private practices, group practices, but most prominently, community clinics. He joined the faculty for the University of Minnesota School of Dentistry in 2006 and was soon selected to fulfill the role of Director of Dental Therapy. Dr. Self manages the implementation of the dental therapy program and teaches dental therapy, and dental hygiene students. Additionally, Dr. Self participates in several nonprofit dental-focused organizations. Involved in the efforts in improving oral health in Africa and its
I think that might be the end of the introduction. It kind of cut out.
Mara, we lost your last couple of sentences.
Do you want me to re-say the last? Okay.
Sounds like they were probably the most important.
Where did I cut off? You don't remember? Okay. He joined the faculty for the University of Minnesota School of Dentistry in 2006 and was soon selected to fulfill the role of Director of Dental Therapy. Dr. Self manages the implementation of the dental therapy program and teaches dental therapy, and dental hygiene students. Additionally, Dr. Self participates in several nonprofit dental-focused organizations. He is involved in the efforts in improving oral health in Africa and is currently researching dental therapy implementation, team-based care, access to care, and global health.
All right. Thank you for that introduction. I'm going to see if I can share my screen and see if we can get the right one up. And okay, can people see my presentation?
Yes, we can.
Yes.
Fantastic. All right. So I'm really excited to be here today and to have an opportunity to share with you a little bit about our 10 years, actually 11 years now, experience with dental therapy in Minnesota. And, you know, you've heard a bit about my background, but I am the director of our dental therapy program. So I have had an opportunity to really watch this grow from the beginning. And let's see here. I think what's important is for people to understand that when, you know, we talk about what's a dental therapist, this is not an independent practitioner. A dental therapist is a part of the team. They play a role similar to a physician assistant in a medical care setting. You know, much like a dental hygienist, they work under the supervision of a dentist. And they're complementary to a dentist. So this really should not be about competition between dentists and dental therapists. They work collaboratively. The dental therapists, at least in Minnesota, are being used to extend the reach of a dental practice, you know, in particular to reach out to underserved areas. And it allows more patients to be seen by the practice. Currently, there are 14 states in which dental therapists are authorized to practice in some way, shape, or form. This map shows states outlined in purple, and those are states in which dental therapists have the ability to practice really under tribal authority. They haven't been granted access to practice in a broader way throughout the state. The states in green have been granted state authority, with Minnesota being the first state to authorize dental therapists in 2019. It's important also to appreciate that the laws governing dental therapy practice do vary state by state. And I think one of the unique things about Minnesota is that, you know, we had we have multiple active dental therapy education programs right now, two of which enrolled students shortly after the legislation was passed. Our legislation was passed in May of 2009, and two institutions took their first classes in September of 2009. Currently, there are 3 educational programs. The University of Minnesota, which again, I'm a part of, and I'll talk more about our program in a little bit, but it's open to all applicants who meet the requirements and standards for admissions. There's 2 other programs now, Metropolitan State, which was the other original institution, and that program was designed to allow dental hygienists to get the education and skill sets to become a dental therapist. And they too were located in the Twin Cities metropolitan area, like the University of Minnesota school. And then a third school opened up this past fall, Minnesota State Mankato. Mankato is about an hour and a half south of Minneapolis, and it's in a more rural area. And it too has set itself up to require you to be a dental hygienist prior to being admitted to the program. So those are the 3 programs that we currently have in our state. Now, our program has evolved over the past 12 years, but some of the keys to our program is that we've always had a program that has integrated our dental therapy students with the education of our dental students and the education of our dental hygiene students. So at the University of Minnesota, we educate all 3 of those student types. And in order to be admitted, you have to have 8 prerequisite courses. And it's the same prerequisite courses that one would have to be admitted into our dental hygiene program as well. And you do not need a degree in order to enter our program. Minnesota is a little unique. Again, we were the first state, and we do have a requirement that dental therapists have a bachelor's degree in order to be licensed. That's not what the CODA standards are currently for programs, but that is the law in the state of Minnesota. So we accept folks after their prerequisites, and as a part of our program, they're eligible to get licensed as a dental hygienist, because they'll get a bachelor's degree in dental hygiene, and then they'll get a master's degree in dental therapy, which again, our state requires in order to practice at the full scope of a dental therapist. And I think, it's important to appreciate and understand, we are a year-round program, 8 semesters long, 32 months total in the program to get that dual degree. Now, we're really proud of our graduates of our program. And one of the reasons why dental therapy has been so successful in Minnesota is that the students who graduate and who come into our program are really passionate about providing care to underserved populations. You look at admissions considerations, and of course, this is the class of 2024, so they started this past September. We have 7 students this year that we were allowed to admit. And although dental therapy is more of a female-dominated profession at this point, we were successful in getting 3 males out of that group of 7. So we were happy about that. They have to show some history of academic success because, again, they're taking courses with our dental students and with our dental hygiene students. You have to be somewhat academically prepared, and you can see that our students have a history of academic success. We're really more interested in other factors, though. Things such as their history of volunteering, community involvement, the things they've done, things we call non-cognitive factors that really highlight a student's potential for meeting the mission of the program. And so in this past class, we see that we had 4 students who identify themselves as racial or ethnically diverse. 5 of the students are first generation students. And of course, because right now Minnesota is the predominant place where they can practice, 6 of the 7 students are from Minnesota. But every year we do get people from other states who are interested in coming in because of their passion for the mission of dental therapy. So how do we know dental therapists are providing care to underserved populations? Well, another one of our state statutes requires that dental therapists practice in underserved areas. It limits them to primarily practicing in settings that serve low-income, uninsured, underserved patients, or in a dental health professional shortage area. And Frank talked a bit about what a dental health professional shortage area is. And just to give you a sense for the state of Minnesota, while our metropolitan area is kind of in the center here, all the areas that are colored in gold or mustard color have been designated as dental health professional shortage areas. So you can see we have a lot of need in our state as well. As of April of this year, there were 120 licensed dental therapists in the state. And if you look at the trend of where they practice, it's not surprising that nonprofit clinics and government-funded FQHC clinics employ dental therapists. They were the biggest advocates for it when discussion was going on about that legislation. But whereas private practice dentists were overwhelmingly opposed to it back in 2009. We now see that they are actually the largest group of employers of dental therapists. Small private practices, which we define as less than 5 dentists in a practice, and larger groups, which is 5 or more. But these 2 categories make up private practice dentists, and you can see there's 58% of the employers of dental therapists are private practice dentists. And that was as of December 2021. All of these statistics are a little bit different now because there were 14 folks who graduated between the 2 programs this past May. And we haven't had a chance to assess where everybody is yet. But the real positive thing for our students is that the demand for dental therapists exceeds the supply of available dental therapists at this point. That wasn't the case early on, but now we're really finding that a lot of dentists are starting to understand what this is all about and how they can add value to their practice and the communities they serve. If you take a look at a map of the state and where they're plotted, and it gets kind of busy, but again, the thing to focus on, we have our metropolitan area here, sort of in the right center of the state. And there's a lot of nonprofits, government-funded clinics, practices that focus on our diverse populations in the metropolitan area. And roughly 63% of our dental therapists do practice in that 7-county metro area. But that makes sense because it mirrors the fact that roughly 60% of our state's population lives in our 7-county metropolitan area. And then if you look outside the metro area, greater Minnesota, and you can see we have folks all over the state. About 37% of our therapists practice outside. And again, that mimics the 40% of our population that lives outside of the metropolitan area. This map also doesn't quite do justice to the efforts of our dental therapists because this are fixed sites where there are clinics that people practice in. And it does not include the mobile work that many of our therapists do that are located in the metropolitan area, but they go out to schools or communities in greater Minnesota for a day or a week at a time to provide care and increase access. So it doesn't count that, but it's a pretty good representation of where folks are in the state. And so what's the impact? What's the effectiveness of it in the time we had? Well, our statute did legislate and require the fact that our Board of Dentistry, as well as our Department of Health, create a report fairly early on to say, is this doing something positive or not? So you can see that this report was given in February 2014. And yes, that's a while ago. But at that time, it noted that there was a decrease in travel time and wait time for patients, particularly on medical assistance, Medicaid, to get into clinics that had hired dental therapists. Clinics that employed therapists saw more underserved patients, and the new patients that were coming in were Medicaid patients and underserved patients. They found that it was more than just adding another provider to the team, that the productivity of the team increased more than you would expect from just having an additional person on the team. And I'll talk about that a little bit more later. It reduced operating costs. And there were no complaints or concerns about quality or safety given to the Board of Dentistry. I put this up here because this framework has held true even to today. You know, we keep talking about the fact that, to the best of our knowledge, there hasn't been any disciplinary action taken against a dental therapist due to quality of care concerns. You know, over time, obviously that will change. There are dentists, of course, who have had disciplinary action taken, you know, against them. But our dental therapy crew is really doing a great job of staying within their scope of practice, providing quality and effective care, and working under the supervision of their collaborating dentists. If we look at what has been done since that report in 2014, there have been 8 case studies done by external agencies and organizations, 2 peer-reviewed journal articles that talk about implementation in various ways and forms. And I've had the opportunity to go visit a lot of the sites, maybe over half of the sites in the state where dental therapists have practiced, and interview dentists, interview therapists, and get data and information about them. And not surprising, we are continuing to find that you know, wait times have decreased, Medicaid patients being increased, that, you know, when dental therapists, we talked about productivity being greater than just adding one person. And what we find is that when dental therapists focus on, you know, prevention and basic fillings and providing care to children, you know, it's like people who specialize in anything. When you do something all the time, you get really good at it. You get faster at it, and it's more efficient to schedule a dental therapist with fillings and with kids, which allows the dentist to focus on a higher level of care, more specialty care. And that varies by the dentist, but you know, they either take on doing more root canals or implants or surgical extractions. Those are procedures that, you know, historically they would have to refer out. And in particular, if you look outside of the metropolitan area, it's hard to find referral sources. People drive an hour or 2 to get to a specialist. Now they can get the care in the clinics in their communities, which increases patient satisfaction, and it's actually increases quality of care, because a lot of patients aren't going to travel to go see that specialist. And so we find that, you know, and in addition, when dentists do those more specialty procedures, they get reimbursed at a higher level. So financially, the clinics are finding that their net revenue, or depending on if it's a for-profit or non-for-profit, you know, clinic, but profits are going up as well. So they can do good by seeing more Medicaid patients and underserved patients, and they can do it in a cost-effective way in which they, you know, generate revenue to be able to expand, in some cases, their facilities to see more Medicaid patients. And so I want to sort of leave with this comment by a dentist. I was in a private practice office in Minneapolis that focuses on providing care to African immigrants. And 80 to 85% of their patients are covered by a government program, such as Medicaid. And I asked them the question, what changes would you recommend to improve the dental therapist's effectiveness in helping your clinic meet patients' needs? And, you know, the dental therapy program is still pretty small. And so his comment was, increase the number of dental therapists in our state. Because he said, our practice, you know, if they were to lose a therapist, our practice cannot go backwards to not having a therapist and having the dentist spend their time on fillings. And he was suggesting that much like today, where most dentists don't do cleanings because the dental hygienist is available to do that, they don't want to go back to doing fillings when they can really provide this higher level of care to meet the needs of their patients. So with that, I will, I think, attempt to end sharing my screen. There we go.
Thank you so much, Dr. Self. Now I'm going to be asking questions for both of our speakers today. Question 1. What is the difference between dental hygienists and dental therapists? Why are both positions important in their own way?
All right, I think I'll probably start with that. And I alluded to that, you know, near the end of the presentation. But a dental hygienist is a professional, oral health professional, who really focuses on prevention. You know, they also do treat some oral diseases, but their treatment of diseases focused on the gums and the health of the gum tissue. And a dental therapist is really focused on the hard tissues or the teeth, and not only in preventing, but they have the ability to do procedures that previously only a dentist could do, like drilling on a tooth and filling that tooth. So together, they're, you know, great combination to have as a part of the oral healthcare team. Frank, is there anything else?
No, I think that covers it simply and easily.
Thank you, Dr. Self. Our next question is, why are the old solutions to improving access to dental care no longer working? Examples include dental care missions of mercy, Medicaid reimbursement rates, and loan forgiveness.
Yeah, so let me handle that one. So, you know, missions of mercy are good things. People get care. Dentists, dental hygienists, and dental assistants and others volunteer. But it's not a system of care. It doesn't allow dignity when you have to wait online 24 hours in bad weather to go to one of these events. Loan forgiveness. I support loan forgiveness to try and get dentists to work in underserved areas. But they're very expensive. And the literature, the scientific literature shows they don't have a long-term impact in terms of dentists staying in those areas. So we've got to try to find solutions that are for the times that we have today. And I was particularly impressed by Dr. Self's slide about the ethnicity and diversity within the class of dental students. I wish dental therapy students. I wish we had that with dental students, and we don't, and we're making a big effort to improve that. But it's more likely that those dental therapists are going to be willing to go back to their rural areas or the communities that they came from. So those are my concerns with the older solutions. We need to look differently at how to deal with this. Mark, it's all set. Okay.
There was a question in the chat as well, but thank you for that answer. Emily Anderson said, I work in a medical/dental integration program, and I am able to see a patient first, and then the patient needs an exam with a dentist. However, for various reasons, the parents do not comply. Recently, we hygienists were trying to increase the number of visits small children could have with the hygienist before their first exam to improve access to care. What is the rule for the dental therapist in a health access setting?
So I'll try to answer that one. So the way the legislation works in most states is that the dental therapist can work under what is called general supervision, as long as they have a written practice management agreement with their supervising dentist. And so they don't need to see a dentist first or immediately after. They just have to have a therapist who is employed and supervised by a dentist. Now, just as an aside, I'm actually finishing up the analysis of a medical dental integration project where we have placed dental hygienists in pediatric medical practices. And it's a little too early for me to say this, but I'm going to say it anyway. It looks like we're getting preventive services to those kids a lot earlier than if those kids just go into a dental clinic for their care. More to follow in about 2 months.
If I can add a little bit to that, based on our Minnesota experience and the sort of follow-up questions about what do you do when a dentist doesn't want to take Medicaid for a collaboration. You know, in Minnesota, we have a number of practices in which dental therapists and collaborating dentists use telehealth to really allow for comprehensive care. So as an example, if a therapist under that general supervision is in a setting where there's not a dentist, they can, collect the information, they can make a treatment plan. Ultimately in Minnesota, that plan has to be approved by the dentist, but it doesn't have to be approved necessarily in advance to care being provided. But there's one clinic in particular that there's never a dentist on site, and they use telehealth and computers on rolling carts to go where the dentist could talk to the patient or the mother, if they're there in real time, and work can be done and referrals can be made and all sorts of comprehensive things can happen. And that dentist could be counties away. It doesn't have to be in a building in the same town even. So if there's no dentist in a given community who accepts Medicaid, somebody from a community that does can collaborate with the dental therapist to make things happen.
Yeah, let me follow up on that too, because Alaska is a great example, which has incredible geography and weather difficulties in terms of access for isolated communities around the state. And again, just as Dr. Self said, the dental therapist and team fly out on a Monday, on a Sunday afternoon, set up a clinic in a hut, literally a medical hut, and they have teledentistry to go back to their dentist if they need to, but they can provide care. One of the community clinics in Minnesota, Children's Dental Services, their dental therapists are serving in 500 sites across the state. That is the power of dental therapy.
Thank you, Dr. Frank and Dr. Self. Our next question is, do health professionals have a certain social responsibility to give back to underserved communities? To what extent is this their responsibility?
So I think this is a really important question, and it goes back to how we sort of name this town hall. There's a lot of dentists who recognize their social responsibility to care for the underserved, but they don't want to take Medicaid because, frankly, in our state, Medicaid reimbursement is just awful. And it's almost as if they lose money by trying to see these patients. So what they might do is see a few patients pro bono. and I applaud them for that. But for those dentists who want to go even further in terms of their social responsibility, dental therapists give them an opportunity to hire a new member in their team that, because of their lower salary, they can afford to see patients who are on Medicaid and deal with the lower reimbursement. So, I mean, this is another reason why I think this is so important. And we would see exactly what we've seen in Minnesota, that the dentists who initially opposed dental therapy when dental therapy started in that state are now supporting it and want more of it.
Thank you, Dr. Frank. Next, how is the dental therapy position an example of social responsibility?
I think I just covered that in my response to the other question about social responsibility.
Yes, thank you.
Okay.
How can Florida take advantage of Minnesota's experience to navigate dental therapy?
I think our experience shows that there's a lot that goes into the implementation of this. You can't, you look at some other states, you can't just pass a law and expect that everything is going to, work smoothly. And so, we were very fortunate in the sense that we had educational programs that were interested in educating dental therapists and sort of ready to go. We see states that have passed laws 6 years ago or so, and still haven't been able to really implement dental therapy because they haven't worked out the educational component. And so I think, that is key, is to make sure that your educational component, somebody steps up and is ready to get folks going. But other than that, it's a lot of work and effort to educate the dentist as to what exactly this is, why it's beneficial, and the value of it. We worked hard to do that early on. It was a slow process, and quite frankly, once we had a critical mass of dentists who had actually worked with therapists who would go and talk to their colleagues, that's when it started to take off. And so making sure that you get some key stakeholders in early, like your safety net providers who are natural fits for utilizing dental therapists, get them engaged, and then have them share their experiences with others. I think those are things that would be really helpful for Florida if they are successful in getting legislation passed.
So let me make an addition to that, and this relates to the question that was posed in the chat by Carly. Realistically, what the time frame is. So my hope is that we can pass legislation probably in the next 2 years. It may take another 3 years. Folks, there have been some states where it's been 10 years to get it passed. Other states it got done. We have a powerful opposition in the Florida Dental Association in our state. So what can you do? I would urge you, if you are interested and you want to help, go to the Floridians for Dental Access website, sign up for our alerts and emails. And when we ask you to, talk to your local legislators. Tell them about the problems you see and you hear and you have heard about, and why we need this legislation in Florida. We've got some exciting developments in the coalition that hopefully we'll be announcing in the next couple of months. Again, I don't think it will be this year, but I'm hoping by the year after. Do we have in Florida interested educational sites? Absolutely, without a doubt. One is a member of our coalition, and that's Miami-Dade College. And I can tell you, you're going to have to take my word for it, there are others that are interested in hosting an educational program. Maura, back to you if we have time for other questions.
Another question of the chat. Emily asked, of those private small practices in Minnesota employing dental therapists, how many are accepting Medicaid?
Virtually all of them. That's part of the reason why they hired a dental therapist. And so, in many cases, you see there's one dentist in a community that will open their practice to Medicaid patients, and so they get swamped. It's hard, as we all know, to find dentists now to go out to some of these rural areas, and so that's how many of them got started. They had no other option. They decided that they would turn to a dental therapist, and so they are the group that does accept Medicaid patients, and they're finding that to be a positive way of continuing to be able to stay open to that.
Thank you so much, Dr. Self. Our next question is, how can we communicate social responsibility to dentists, such as the inclusion of the dental therapy position in their practices?
So, a couple of years ago, for a number of years, I ran the Ethics and Professionalism course at the University of Florida College of Dentistry, and I introduced it there. I talked about social responsibility. I talked about our moral obligations as healthcare professionals to care for the underserved, and I raised the topic of dental therapy during these discussions. Unfortunately, the students only get one side of the issue from organized dentistry, and that's dental therapy is bad and dental therapy is a threat to them. But again, if we look at Minnesota, that's not what dentists think after having exposure to dental therapy for now 10 years or so. So it's just a matter of continuing to talk and reminding my colleagues about their social moral responsibilities as a healthcare professional.
And if I could add a little something too, I think one of the reasons Minnesota was successful early on is because of the coalition of people that we had pulled together who knew about the dental or the oral health crisis. People involved with housing, food banks, our medical colleagues. Everybody's aware of the difficulty in underserved folks getting oral health care. But until we sort of pulled them together and said, if we're going to ever do anything about it, we need all of you to be advocates with us. And I know that's what Frank is doing with his Florida Alliance as well. But getting, those key opinion folks in various areas to get out there and share that this is an issue we need to take seriously and work with their legislatures. And I think, because of that medical dental interactions, we really do need to do a lot more work interprofessionally and collaborating with our medical colleagues to talk about that with their patients and the public, to get them energized about possible solutions to these problems so that they can also be knowledgeable enough to advocate.
Thank you so much for those responses. Another question in the chat from Manuel regarding the high demand for dentists in Florida. Do you believe that the reason for this high demand has anything to do with how difficult it is to get a dental license in Florida?
So let me handle that one. I know a little bit about this topic. So decades ago, there is no doubt that licensure was difficult in Florida, and there were actually legal actions with the Board of Dentistry about the licensing process. I do not think that is true anymore. So I do not think this is related to how difficult it is to get a dental license in Florida. I think the exam is fair. I'm not a proponent of live patient examinations, but I think that they are doing the best job they can under the circumstances. At some point, I'd like to see us move away from live patient exams, and some states are starting to think about that. But I don't think it's related to how difficult it is to get a license in Florida.
Thank you, Dr. Frank. And our last question is, how can we communicate the importance of the oral health crisis to the public? What are specific actions that people or organizations can take?
So again, our organization puts out press releases. We have fact sheets within on our website that talk about these issues too. And, we try to communicate with legislators. We try to communicate with other policy people, and we're trying to grow our organization. The Urban League of Jacksonville is a relatively new partner, just a couple of years within our organization. We want more organizations like that who can help spread the word by doing events like tonight and letting people know this is not a pretty smile. This is not fresh smelling breath. This is your life. This is your health. This is your children's achievement in school. Our newest partner is American Children's Campaign, a Florida organization that is a primary advocate for children's issues. When I discussed this with them, they immediately got it and signed up to be members of our coalition. Immediately, they absolutely understood, and we're going to work with them to sell our message better and more effectively across the state, so we can pass the right legislation.
And also, Dr. Frank, I remember the Population Health Consortium.
Yep.
The minute they heard the information, went out in support of the program and is a consistent partner in that regard. And that's made up of some significant healthcare professionals and organizations, hospitals.
Yep.
In Northeast Florida.
Thanks, Ben. That's absolutely right.
Yeah, it's just, well, I work with that group a lot, and they're very, very much focused on this gap in equity when it comes to access to healthcare, and the sad case of oral health access.
I just want to make one correction to something I said earlier. Sue, thank you for your comment. We do now have a mannequin, not live patient examinations in Florida. I don't know enough details about that to say more than that, but for those that are interested, this came about during COVID, and it was not a lot of good effects of COVID, but this might have been one of them.
And if I could just jump in quickly to answer the last question about the difference between a dental therapist and a military expanded function practitioner, is the fact that a dental therapist can actually drill and remove decay and prepare the tooth, whereas the expanded functions person generally places the filling once it's been prepared by a dentist.
Thank you for those responses. There was also another question in the chat that wasn't answered before. In our state, we just don't have providers, DDS, that will see Medicaid. If the DDS is a long distance away, how does that patient ultimately get care? Drive 4 to 5 hours?
Well, that's occurring today. So the dental school is one of the largest Medicaid providers in the state. Our dental clinic and the pediatric dentistry clinic still has patients that drive 2 hours away. This is what could be alleviated with dental therapists, because dental therapists can again, working under the supervision of a dentist, but not necessarily in the same building, be able to provide care where the patients are. One of the things that the Children's Dental Services that I mentioned earlier does is that they go right into the school system. So now mom and dad doesn't have to take 2 hours off from work to bring the child to a dentist. The child is getting care in the school by a dental therapist. Enormous savings of time for these parents who are already stressed, with their hourly jobs and worrying about having to take time off.
Thank you so much, Dr. Frank and Dr. Self, for speaking.
Yes, I want to echo that and echo some of the comments that I saw in the chat about the gratitude that has been expressed for the work of Dr. Frank and Dr. Self and your organizations. We're very appreciative, and we look forward to continue to work with you. And Cindy Wampler actually sent me a note saying she's happy to work with us. We're going to collaborate on that and put her to work. So
Great.
again, thank you to our interns and all the work that they do. We could not operate the center without their assistance and their brilliance. They, in fact, we're doing a presentation tomorrow, Thursday, on this very topic at a healthcare a virtual clinic. So just grateful for their support. And on behalf of the Urban League and Dr. Danford, our president, I want to thank all of you for attending. Thanks to our speakers and our interns for all your efforts.
Great. Thank you very much for sponsoring this. Appreciate it. Thank you, Carl, for participating.
Thank you for inviting me, and I appreciate being able to share.
Great. Take care. Take care, everybody. Thank you.
Great
Thank you
evening.
for your questions.
Thank you.
Have a great evening and great rest of the week.